Hi everyone and welcome back to part 3 of this keynote presentation. So in this part of the presentation I am going to tackle 6 key questions or issues that have emerged from our work and from the existing literature. And these questions are about how the nurse-patient relationship should best be measured. So these are the 6 key questions and I'll go through each of them in turn. So the first issue or key question is whether different instruments are required for different contexts and for different patient groups as well, or whether the relationship can actually be measured through a set of foundational behaviours that transcend context. Most of the instruments that we reviewed, for instance, in the studies I talked about previously, had been used in or developed only for one specific context or potentially one patient group. And context obviously plays a really large role in how the relationship can be developed and how it can be maintained as well. But we have to ask ourselves, given the centrality of the relationship to nursing practice in all settings, it's arguable that the way in which this relationship is developed and maintained is not so markedly different that we actually need different instruments across different contexts and patient groups. At the very least, we probably need to ask ourselves, do we need 35 different instruments to measure the nurse-patient relationship? The second key issue or key question regarding measurement concerns the impact that an instrument's development or its aims and scope actually has on its subsequent utility and applicability. So, for instance, many of the instruments that we reviewed had no patient or nurse input or involvement, either in their development or in their refinement, and typically both. So this raises the question as to how useful instruments measuring the nurse-patient relationship are when the expertise and experience of nurses and patients is missing. Also, what we found was that very few instruments could be used in multiple languages or could be completed by multiple different people, different assessors, and few had been used in multiple contexts as well. So the applicability of existing instruments to the many varied circumstances and settings in which the relationship takes place appears to be limited. A third key issue around measurement is that some of the existing instruments that we reviewed incorporated items that assessed more procedural or technical care. So, for example, IV management or medication administration. So this raises the question as to whether this type of activity is part of the nurse-patient relationship. So it could be argued, for instance, that delivering this type of care safely and competently is a central way in which you can build trust with patients, which then can enable a relationship to develop. But you can also argue that a nurse can administer medication or manage an IV in the absence of a relationship with the patient or in the presence of a bad one. So simply performing a procedural task like managing an IV is vastly different to actually performing that care in a relationship-centred manner, where the task is also accompanied by efforts at rapport building. So completing a task in the absence of a relationship arguably reflects what we often refer to as a task and time approach to care, whereas providing care in a relationship-centred manner reflects a thinking and linking approach, so where nurses are able to integrate and coordinate patients' various care needs across their healthcare experience. The fourth key issue that I wanted to tackle concerns the level of detail or specificity that instruments should capture when they are measuring the nurse-patient relationship. So, the items of most of the instruments that we reviewed could be considered higher order in that they provided very little detail and often were vague or ambiguous or open to interpretation. Some items were more detailed, but that was typically less common. So these less detailed items are arguably more subjective and they might be difficult to observe or report on because they require greater interpretation on the part of the person who is actually completing the instrument. But trying to capture in detail all the possible ways that nurses might establish and maintain relationships with patients and what this looks like, so for instance verbal and non-verbal activities, facial and vocal expressions, trying to capture all of that might lead to an instrument that is just too long to actually be useful. But of course such detail might better capture that thinking and linking approach to care. We also have to consider that items which seem vague or open to interpretation can be advantageous because they don't constrain respondents. So think of an item such as "the nurse respects me." So people will likely perceive different actions as constitutive of respect, so it might not be possible to capture all of those different variances in a measurement instruments. And if we attempt to define respect in a very prescriptive way, it might exclude some people's interpretation of it. Instead, it might be sufficient to simply ask people whether they felt respected, however they interpret that to be. And that then reflects how relationships actually occur in practice. So these relationships inevitably involve different individuals with different goals and different needs that are idiosyncratic to that relationship and those individuals involved. But of course, items that are ambiguous or open to interpretation do pose some challenges. So for instance, how do we interpret findings from an instrument whose core constructs aren't well defined but are instead open to interpretation? And how useful are these instruments in clinical practice and educational contexts where we need to define constructs such as respect and trust for the purpose of educating students, for directing care delivery, and of course for benchmarking? So if we think more specifically about documenting the relationship within electronic records, if we don't have a consistent interpretation of the core elements underpinning the relationship, then what use is that documentation? Will we actually be able to use it to direct patient care? Will nurses be able to use it to communicate care plans with each other? And of course, if we can't benchmark appropriately, or if we can't document the relationship on a broader scale that will facilitate comparisons, then we don't necessarily have the evidence that we need and that healthcare systems need to actually direct service improvement and ultimately improving patients' experiences. So the risk here is that once again, the relationship is undocumented, it's hidden, and it's largely ignored. So a fifth issue that I want to look at is whether and how patient behaviours should be incorporated into conceptualisations and measures of the nurse-patient relationship. So a lot of the work that we have done to date has looked primarily at nurse behaviours. And I will say that most commonly the constructs that are thought to constitute the relationship are seen as attributes that the nurse must possess or something they must perform. So for instance, they must be trustworthy or they must work to develop trust. So a lot of the onus is on the nurse. So less commonly there seems to be recognition that these constructs like developing trust are formed as part of a mutual negotiation between the patient and the nurse, where patients are more than just passive recipients of nurses' actions. And it's been argued that it's only through patients actively participating and being willing to participate that a relationship can actually develop. And that might seem obvious, but of course for some patients that more active involvement is not always possible, whether it's due to issues such as cognitive impairment or simply because they're unwilling to engage in such a relationship. But these challenges don't necessarily render the relationship irrelevant. In all instances of care, the nurse must still actively manage the relationship and moderate their own behaviours to actually accommodate those of the patient and to achieve the desired health and care goals. And of course, part of that process as well involves the nurse continually evaluating the quality of the relationship too, so that they can actually determine whether it's having its desired impact. But as I mentioned in part 2 of this presentation, this evaluative process on the part of the nurse is not typically captured in existing measurement instruments. So the final issue I want to look at is around whether the nurse-patient relationship should be conceptualised and measured as dyadic, in other words, as involving just one nurse and one patient. Many scholars argue that the relationship is much more dynamic than this. And of course, given the rise of chronic illnesses and an ageing population, more and more people are accessing healthcare with a carer or a family member who is involved to more or less extent in that person's care. And of course, when someone is accessing healthcare, say they're in a hospital setting, they are typically seeing multiple health professionals as well, not just the nurse. And those healthcare providers all have professional relationships with each other as well. And they of course have relationships with the patient. So this becomes a much more complex, interconnected network of professional and caregiving relationships. But the instruments that we looked at focused simply on the nurse-patient relationship as involving those two parties, one nurse, one patient. Now, of course, this could be due to the types of measures that we actually looked at. So we were looking at survey instruments, and these are objective metrics that are often inherently reductionist, and they reduce some of the complexity of the concept that they're measuring so that these instruments can be administered quickly and easily. And measuring the relationship in a way that reflects that more complex interplay between multiple parties is arguably challenging. And we do have to consider, though, that it might not be feasible to capture the relationship using a traditional survey instrument. So we have to be creative in thinking about other ways of measuring the relationship effectively. So before we move on to the final part of the presentation, I do have some more discussion questions for you, and once again I invite you to spend around 10 to 15 minutes discussing some of these issues that I have brought up in this part of the presentation. And then after that I'll see you back for part 4, the final part of the presentation.